Good afternoon. Welcome. We're so happy that you could join us today. My name is Tamara Bingham. I'm the Director of Business Development at Center for Change. I'm here with Quinn Nystrom, our presenter, and I'll introduce Quinn in just a minute. We're really happy to be with you all today and grateful you all could join us. I have a couple of things you'll see on your screen that we want to go over really quickly before we turn things over to Quinn. So we'll go over those items now. So a copy of the PowerPoint is in the handout section of the toolbar. If you look on your GoToWebinar toolbar, you'll see a section that says handouts. If you'll click on that, you'll see the two handouts that are available there. The first one is the copy of the PowerPoint that Quinn will go through today. If for some reason you can't see it or you can't download it from GoToWebinar, you can also get that PowerPoint on our website at centerforchange.com. Go to the professionals tab and then you'll see our webinars tab there as well, and you'll see the PowerPoint and the a copy of the post tester there. A copy of the post test is also in that handout section of the toolbar. That's for reference only. You must take the test online in order to receive continuing education credit, but you're welcome to take a look at that test throughout Quinn's presentation so you can keep an eye for those test questions as they come up. You're welcome to submit questions in the questions section of the toolbar. We'll try to get to some of those at the end of Quinn's presentation. I'll keep an eye on those throughout Quinn's presentation, and then at the end, I'll ask Quinn some questions. We recognize that many of you are clinicians and will need to hop off at the top of the hour. So we'll save a few minutes before the top of the hour for questions. And then if we go over and you have to hop off, we completely understand. That's okay. When, excuse me, when the webinar ends, there will be an evaluation that will pop up on your screen. If you would take just a minute to fill out that evaluation, we would appreciate it. That's a continuing education requirement for us. It's completely anonymous, so please feel free to be candid in your feedback. We tabulate those results and then send those to the CE providers as part of the CE approval process. And then about an hour after the webinar ends, you'll receive an email from GoToWebinar. It will look similar to the email you got, the confirmation email you received when you registered. This will be a separate email, as I said, that will come about an hour after the webinar ends. In that email is the link to take the online test. Again, you must take the test online in order to receive continuing education credit. Once you pass the test, you will see a button that will pop up that will allow you to download your certificate. So keep an eye out for that and then click on that button and then you can download your certificate or print it from there. Okay, I'm excited to be here with Quinn. We've known each other for a long time now. Quinn is an amazing human and an incredible presenter. She's my friend. We have had the opportunity in prior to pandemic years, we got to travel quite a bit together and spend time together as we went across the country, and Quinn talked about type 1 diabetes and eating disorders. And so it's been a blessing for me to be able to spend time with Quinn and call her my friend. She's an amazing advocate for the type 1 community and especially is very involved in insulin affordability and insulin for all, and I'm sure you'll hear some of that about that from Quinn today. She's an author. The book is called If I Kiss You, Will I Get Diabetes? And it's a great book. In fact, we give it to all of our EDDMT1, so patients with type 1 diabetes and an eating disorder. We have a program for that at Center for Change, and for all of our patients, we give them a copy of Quinn's book for them to read and their families as well. So it's my pleasure to turn the time over to Quinn. Quinn, I'm going to send you the screen. So let's get that up and running first. You should see it on your screen. There it is. Okay, I'm going to turn off my my audio and my video, but I'm here if you need me. So holler if something goes wonky. Otherwise, I'll pop on at the end and we'll address some questions.
Okay, sounds good. And I just touched the wrong thing here. So let me okay, good. So everybody hopefully can see my PowerPoint. So Tamara and I were just talking at the beginning of this saying, oh, sometimes this technology, we think we've gotten so good at it, especially, after the pandemic, during the pandemic. But it's shocking at how many reminders I still need for these kind of virtual webinar events. So first off, I want to say thank you so much for attending. I know everybody has really busy schedules, and so I appreciate everybody registering, logging in. I know everybody's time is precious, so I really appreciate it. Second, I will say my insulin pump is low on insulin. It's just fine. I'm doing great. But if you hear beeping, it probably is me. No need to worry. I always have my fruit snacks and I have drinks around me and food around me. But just if you hear beeping, if you know anybody with diabetes, unfortunately, there's no way to silence some of those alarms. So I guess it's all par for the course, and it's perfect because we're giving this presentation in November, kind of in honor of November being National Diabetes Awareness Month. Diabetes is such a passion of mine. Some of you may have attended past webinars of mine, or I write a monthly blog for Center for Change and sort of followed some of those blogs. And so really appreciate for everybody returning, and welcome to anybody new who has not joined one of my webinars yet. So really appreciate it. And again, I really encourage you, if there's a question you have, either related to like what I'm speaking about or diabetes related that you would like to ask, please send those and submit those as kind of Tamara had requested. I will save time at the end, and I will end my presentation a little bit early so that if you do have to leave at the top of the hour, that we have some time to get in some questions. So I really love hearing questions and getting to answer to the best of my ability. So today's topic that I selected with Tamara was social media's impact on mental health and the complicated relationship for people with diabetes. And a large part of the work I do, so, you know, I've been talking about diabetes for 25 years now. My younger brother and I both have had type 1 diabetes since we were quite young. And so for me, a big passion is how can I, you know, use my communication skills, my master's in communication research that I've done around that topic to try to best explain to people maybe who are not living with diabetes, who are medical professionals, caregivers of people with diabetes, to try to give better maybe context into day-to-day life, how things may be impacting us. And I always like to start out by saying, I will certainly share stories. I will show screenshots of things that people have posted to me and others on social media. You know, my job is never to kind of tis other people. I usually always believe the best intent. You know, have I had negative experiences with healthcare professionals? Yes. Have I had amazing experiences with healthcare professionals? Yes. Even in those sort of more unfortunate situations, I don't believe the healthcare professional was ever trying to be malicious or trying to be negative. I usually look at, I think there's a misunderstanding, or maybe they're not understanding sort of the full scope of what life is like for me living with a chronic incurable illness. So a big sort of focus of my work is how can I try to really personalize things and put things in perspective. And again, I don't speak for the 30+ million Americans in the United States that live with diabetes. You know, I'm certainly sharing my personal perspective and the opportunities over the last 25 years that I've had, speaking to over 300,000 people, a lot of people being impacted by diabetes in one way or the other. So again, not the be all end all expert here, just wanting to kind of give my thoughts and hope that it helps you along your journey. Because what I know about healthcare professionals is you mainly all went into it because you wanted to better people's lives and you wanted to improve those people's lives. And so I hope that this webinar today can continue to help you on that journey of helping other people. All right, so the agenda today, I was going to start out with social media use. I had a video on there that is not working. So, but if you do go to my PowerPoint, you're able just to put that into YouTube. It really talks about, in my opinion, how scary, just how common it is, right? And how much we rely on social media these days, how much time we spend on it. Um, you know, I grabbed a couple just quick stats. You know, I have an iPhone, a lot of people have iPhones. You know, on average, people spend over 3 hours a day on their iPhone, directly on their iPhone. It said that 1 in 5 people spend upwards of 4.5 hours a day on their iPhones, right? And when you look at social media, on average, an American spends around 2.5 hours. And I know that we have a teenager in our house, and that number is probably pretty conservative. I also sometimes teach at a local high school, and I would think 2.5 hours a day would be more of a conservative estimate of social media use. But feel free after the presentation, if you're interested in kind of what are those stats, those recent stats, to watch the video, because it is very eye-opening. Then we're going to talk about the Surgeon General's 2023 report that came out in May, which I think was very eye-opening. Yeah, many of you probably read about it. Talking a little bit about the harms of social media. I'll give a little bit of a just quick diabetes 101, and then some barriers to diabetes care. And then sort of wrapping up at the end, you know, sort of the positive and negative impact of social media for people with diabetes, and then action items and strategies for patients, caregivers, and healthcare professionals. Some hopefully helpful takeaways. All right, so the US Surgeon General came out in May, and this was specifically focused on social media and youth mental health. It made a lot of big news because, again, you know, I think there's always been a lot of talk about social media use and negative impacts, but the research really hadn't caught up or it wasn't substantial enough. And so the Surgeon General, you know, kind of took this, I think, you know, pretty big stance to come out with this report. Sorry, I just got to get this window so that it doesn't block my quote so I can read it to you all. But so the Surgeon General, the United States, said the most common question parents ask me is social media safe for my kids? The answer is that we don't have enough evidence to say it's safe. And in fact, there's growing evidence that social media use is associated with harm to young people's mental health. Children are exposed to harmful content on social media, ranging from violent and sexual content to bullying and harassment. And for too many children, social media use is compromising their sleep and valuable in-person time with family and friends. We are in the middle of a national youth mental health crisis, and I am concerned that social media is an important driver of that crisis, one that we must urgently address. And in that report, they pulled a lot of, you know, kind of a lot of research. And so some of those key findings were, you know, adolescent social media use predicts a subsequent decrease in life satisfaction for certain developmental stages. So for girls, they were looking at about 11 to 13, boys around 14 to 15. Adolescents who spend more than 3 hours per day on social media face double the risk of experiencing poor mental health outcomes, including symptoms of depression and anxiety. In US colleges, when they looked at social media rollout, again, so, you know, I graduated college in 2008. So I remember like 2004, 2005, when the Facebook was coming out, right? That was kind of the beginning of a lot of those big kind of social media trends and usage going up. But they looked at those years, right, where that changed, and they saw that when those rollouts were happening, that there was an increase in depression and anxiety amongst college-age students. So a study in college-age youth found that limiting social media use to 30 minutes daily over 3 weeks significantly improved depression severity. A study conducted among 14-year-olds found that greater social media use predicted poor sleep, online harassment, poor body image, low self-esteem, and high depressive symptom scores, with a more significant association for girls than boys. And, we have a teenager in our home, and I remember being a 13-year-old girl with no social media, really kind of not what the internet is today. And there is no amount of money you could pay me to go back to that age, right? It was brutal. I wanted to fit in, I wanted to blend in. And now in 2023, most kids have a cell phone by the time they're a teenager, right? By the time they're 13 years old. We see kids getting smartphones, at 5, 6 years old, getting full access. I was listening to Minnesota Public Radio. I'm based out of Minnesota, and they had a really interesting report on social media, and they were talking about Snapchat and TikTok, and a mother had kind of put information in before she let her daughter create a profile, and she put in her daughter's age, being 14 years old. And obviously the platforms have told Congress, have told the world, that they only do age appropriate content for minors, for adolescents. And this mom was sharing on this radio show just how traumatized she was to see the content that was being directly delivered to her teenage daughter, right? And that it was really scary. And the mother ended up not letting her daughter join or have that be part of her phone because she was so scared about that content that was being directly delivered. We do see on the federal level, Congress trying to step in and try to moderate some of that. But again, it's really difficult to do, right? And I'll say this as a parent, we've purchased every parental app, we've purchased, everything, and try to stay on top of things and check phones and have open and honest conversations. And kids are smart, and they know how to get around things, and it's really difficult to moderate all of that. So, and certainly, right, back in my day, we would pass handwritten notes to each other. And now kids, are their own citizen journalists and can write anything on, again, TikTok, Snap, things can be shared, gossip can just be spread like wildfire. And we see this really taking a huge hit on our youth, and our youth who is already struggling with a lot of mental health concerns, issues, diagnoses. And so I think it's a really important conversation as a country that we need to continue to have about how can we all work together to see what we can do and really help support young people in this. So, studies that have examined social media harm, right? There was a study that was done, more than 12,000 13 to 16-year-olds. This was in England, but found that using social media more than 3 times a day predicted poor mental health and well-being in teens. There was another study, more than 450 teens found that greater social media use, nighttime social media use, and emotional investment in social media, such as feeling upset when prevented from logging in, were each linked with worse sleep quality and higher levels of anxiety and depression. I've talked to a lot of parents and guardians that they almost don't even want to start the fight with their teenager to try to put up some strong boundaries because it elicits, there's a lot of talk about, can people be addicted to their phones? Can they be addicted to social media? And seeing real strong feelings and emotions come up when you try to remove that source. So social comparison and feedback seeking by teens using social media and cell phones was linked with depressive symptoms. I know I talked to a teenager at an event this past year who told me that they got a lot of ideas about cutting and self-harm from TikTok, that they were able to research different methods to cut weight quick. I think as adults, right, it's just crazy to think, right, that I can go onto my phone, Google anything, and it's like the world is at my fingertips. Some of that's moderated and a lot of it is not. And it's scary when we have young people whose brains are not fully developed yet, who also have the same exact access as us adults, who may be able to decipher from our life experience, from our knowledge, from our brains being more formed, what is good information to take in and what is harmful information. For instance, I know there was talk in a parent group I was in this last week, and we were talking about just the horrific images that some of our kids and teens were seeing coming out of Israel, right? And that, we're not able to moderate that completely. And so just seeing things, I think that maybe a lot of us, maybe in our youth, did not experience because we didn't have access to information like that. So lastly, on this slide, older adolescents who use social media passively, such as just by using other photos, reported declines in life satisfaction. I think there's a lot of studies, you've probably read them as well, talking about, spending X amount of minutes a day on the phone will decrease your self-confidence, your self-esteem. It's sort of the social media comparison game, how most people want to put really flattering things about themselves on social media. It's not a totally accurate depiction of what somebody's life may be like. There's filters used, there's curated information used, there's tracking, there's targeting. And so again, how can we communicate to teens, to educate them more about the dangers and again, sort of how it works and the harm that it can cause to their physical and their emotional health. I know I was at a presentation, a couple months ago that our church put on. It was about social media usage and teens and talking about one of the biggest things we can do is by removing cell phones, computers, iPads, you name it, from our kids' rooms, at 8:30 p.m. And making sure that they're in a central location. And as parents, how can we model that? So, Facebook keeps on growing. Back in 2004, when it was called the Facebook, when I was going to undergrad, right, we see this massive spike. We see, the world population being right under 8 billion people, and Facebook users are 2.8 billion. And so a lot of us use it, right? And Facebook has been very clever, right? To not, what started as just kind of a profile for college students has really evolved, right? There's Facebook Marketplace, there's where people consume news, there's where people find events, right? And just kind of putting all those different aspects of our lives so that we will stay on Facebook even longer and have it be kind of our go-to source. So, the study was, they really leveraged the staggered introduction of Facebook across US colleges because they wanted to see how that impacted mental health. And they found that the introduction of Facebook at college had a negative effect on student mental health, showed individuals now receive information about their social network directly in their newsfeed. And that information is more relevant to them because it is ranked by an algorithm. Facebook wants you, and other platforms want you to stay on as long as possible. And so they have very smart people who continue to make this algorithm, as good as possible to make sure that we are on board and then we leave. My husband and I will sometimes joke, we will have talked about something, him and I, and then like a couple hours later, he's getting targeted ads on that topic, right? He has not searched on his phone. And so, again, I'm not a conspiracy theorist, or I don't go down that rabbit hole, but it is surprising to both of us, conversations that we have, and then, you see these targeted ads for you. And I'll say right now, I'm 7 months pregnant, and granted, I do look at things on my phone for pregnancy and things like that, but all my ads and videos are targeted to new moms. And oftentimes I will purchase those items, right? They're just being like totally directed at me. So The content on the platform is richer in that it often includes videos, right? We saw that as a kind of a new intro. Obviously, it did not start like that back in 2004. These changes might make Facebook even more engaging and might exacerbate the effects on mental health. It also increased the likelihood that students reported experiencing impairments to academic performance due to poor mental health. Our evidence points to unfavorable social comparisons as the leading mechanism of that decline. Again, I sometimes teach at a local high school, and I know last Friday, a lot of the kids at school were laughing because Fortnite came out with something overnight, and kids were up till 4 or 5 a.m. because there were new maps or old maps. I really don't know much about Fortnite, but and then parents were calling in sick for their kids on that Friday so that the kids could play this Fortnite and whatever the new release was, or vintage maps. I'm not quite sure what it was. And it's very difficult to get kids to then get off their phones, even for class, right? It's a real struggle. Sometimes I kind of chuckle and say, I feel more like a phone police than an educator. And so that can be really tricky when we have that, and then seeing how that impacts their sleep. And then we know that can impact their eating pattern. It then, right, it's just this like boomerang and kind of snowball effect. So, you know, probably a lot of the information I talked about is probably fairly familiar to all of you. And so again, my passion is trying to help then people better understand kind of how do people with diabetes fit into this, right? So that's kind of now the next part here that we're going to discuss. So for everybody who's really in the know about diabetes, you can take just a quick little breather here. But I always do like to make it a point, because I do get comments from people who attend webinars or presentations of mine that just they don't have a lot of background knowledge on diabetes. So I'm just gonna do a quick diabetes 101 in about 1 minute. So diabetes means you have too much sugar in your blood, which can harm your body over time. There are two main types of diabetes, and both deal with insulin, a hormone that helps convert sugar to energy. We know about 1 in 10 Americans have diabetes. This number kind of goes up and down. So type 1 diabetes, they call it insulin dependent. About 5% of people with diabetes have type 1. Again, we're right around the 32 million mark in America for people with diabetes. So obviously this is the least prevalent type. It used to be called juvenile diabetes, and we would call type 2 adult onset. Those terms went away because we were no longer seeing that just kids, right? People under 18 were getting diagnosed with type 1. And we were also seeing that it wasn't just type 2 people was sort of a senior citizen disease, right? We saw those numbers really go away, and seeing that people as young as elementary school could be diagnosed with type 2. We saw, I know a woman here in my hometown who was diagnosed with type 1 at 35. You know, is that more rare? Yes, but it does happen, right? And so those names of calling it juvenile and adult onset were inaccurate. And it was also causing people to be misdiagnosed, which was causing a lot of issues. And so anyways, you may still hear those terms thrown around, but the proper ones to call it are type 1 and type 2. Type 1 diabetes. So pretty much for somebody like myself and my brother, our pancreas shut down. Our body does not make any insulin because the cells that make insulin have been destroyed. Type 1 is an autoimmune disease. I always tell people, you know, my parents could have put me on the hamster wheel and fed me spinach. I still would have gotten type 1 diabetes. So there was nothing at this point that researchers know that can prevent the cause of type 1 diabetes. They believe you may be predisposed to it, and then something along your life kind of triggers it. But we know a lot more about type 2 than we do with type 1. So type 2, your body is still making the insulin, but it's not meeting your body's need to control your blood sugar. So that's why they call it insulin resistant diabetes, because again, your pancreas is still producing insulin, but it's the insulin resistance issues. So both of the issues have to do with your blood sugars and blood sugars being elevated. And that's why some of the treatments may be a little bit similar. But again, still two separate diseases. So symptoms, extreme thirst, frequent urination, blurry vision, tired or weak, slow healing wounds, unexpected weight changes. Prevention, right? Type 1 cannot be prevented and the cause is unknown. Again, there's a lot of different things out there that are being researched that genetics and environment may play a role. For type 2 diabetes, again, I can kind of get up on my soapbox if you've been to other presentations of mine. The cause is still not fully understood. And I think there is a very strong perception in America that you can eat your way in and out of diabetes, right? And we'll often just hear it, diabetes. Now, I understand people are meaning type 2 diabetes, but I think it's really unfortunate if we continue or fuel that dialogue in any way. With type 2 diabetes, there's 12 different risk factors in getting it. Are a couple of those risk factors obesity, inactivity? Yes. But we also know in America, the percent of people with obesity is not the percent of people with type 2 diabetes. It is not a one-to-one correlation. And so again, I think shaming people, blaming people for a chronic incurable illness diagnosis is not helpful. I don't think it's motivating. I also think it's wrong. There's other things with type 2 diabetes. Genetics play a very strong role. If somebody had gestational diabetes, so did they have diabetes while they were pregnant? Older age, right? There are a lot of people, if you go to a local nursing home, who have type 2 diabetes and they may be 95 pounds, right? Their body just is not functioning and working like it used to. My grandpa celebrated his 98th birthday on Monday. He is a World War II vet. He has type 2 diabetes. Like, the guy's doing great. But like his body just does not function like it did when he was 20 years old. So anyways, I'm going longer for a minute on this, but I can get really worked up about it because there's a lot of people that I know with type 2 diabetes that will not go in for medical appointments because they feel so much blame and shame around the diagnosis. So it's just, I always have to kind of fit that in somewhere. So again, treatment for somebody with type 1 diabetes, because your pancreas is not working at all, to stay alive, you need insulin. That is your life support, it's your oxygen. So either you're gonna take multiple insulin injections a day, or you're gonna be on an insulin pump. Somebody with type 2 diabetes, again, a diet or exercise program may be discussed if that seems to be the issue around the insulin resistance, but there may be oral medications. And in some cases, you will see people with type 2 diabetes who take insulin injections. And now, in more recent years, you will see people with type 2 diabetes wearing insulin pumps as well. So, sometimes I hear this thing of somebody being like, well, I take insulin, so I have type 1 diabetes. Again, that's not how we diagnose and decipher between type 1 and type 2, because there are a lot of people with type 2 that do take insulin. And actually 7.5 million Americans, right around there, rely on insulin every day to keep themselves alive. And I think the number of type 1s is, well, math was never my forte, but I think there's 1.5, 2 million people in the US, roughly, give or take, that have type 1 diabetes. So there is a large number of type 2s who do have it. So people with diabetes make an additional 300 decisions a day. So, we have everything that everybody else has. And then, my parents used to call my little brother and I, like these mini scientists, because here we were given this disease where now we have to know what our blood sugar is at all time. We have to know our insulin dosing. We have to know how many carbs we're eating. We have to know how maybe the stress of a test would impact those blood sugars, how I was a competitive figure skater growing up, how a figure skating practice or a competition impacts that. And so we're having to make all these additional decisions that are actually very much life or death. If you know somebody with type 1 diabetes, I don't think, well, I have a vial around here, I'm sure, in my purse, but the reality is, so here's this is an insulin pen that you will see some people with. This is, again, if people are doing insulin injections. And You'll never know what you'll find in my purse here. It could be kind of a scary thing. I probably should have pulled these out before, but somebody with type 1 diabetes, you're taking a very small amount of insulin, right? It's not really large amounts, and it impacts you greatly. And so if I give a little too much because I thought, well, this was 45 grams of carbohydrates, but really it was 15, my blood sugar is going to drop low. Or if I underestimated it, right, my blood sugar is going to go high and I'm going to start feeling pretty sick. I'm going to have to start going to the bathroom more. I'm going to be more thirsty, right? So all these decisions then have a direct impact. As medical professionals, you're trained, right? Our endocrinologist knows the ins, the outs, all of that. I told you I'm horrible at math, but here I am, now coming on 23 years with type 1. My brother, I think, just celebrated 25, 26 years. And you're having to do all these math calculations, which I'm horrible at. And they are life and death decisions every single day and multiple times a day. And that is exhausting, right? I think just regular life is exhausting. And then you throw in, again, I can only speak personally of type 1 diabetes, but type 1 diabetes, it is exhausting and it is an additional full-time job. I love to show this chart. This is from a great organization called Diatribe. Feel free to check them out, but here's 42 factors that affect my blood glucose, right? Obviously the up arrows would be that my blood sugar would go up. Midway would be maybe it doesn't impact it, and then a lower arrow would mean my blood sugar would drop. So you see different food, you see medication, you see activity, you see biological, right? We're talking about insufficient sleep. We're talking about stress and illness. We're talking about scar tissue. We're talking about where do I inject myself? Again, I'm trying to do a good spot, but sometimes, right, we hit the wrong spot and the insulin is not absorbed correctly. So we have puberty, we have celiac disease, you have environmental, you have behavioral and decision making. And so sometimes, I'll wake up and I'll have a high blood sugar and I could tell you the exact reason why I have that blood sugar. One of these things from the chart, I feel like I should just leave like a little print of it in my purse and I can like hand it like, well, it's one of these 42 things. Because sometimes, honestly, I wake up with a certain blood sugar and I cannot tell you why I'm sitting at 200. Like, I have no idea. Your guess is as good as mine. I'll give you this chart and you can pick 1 in 42 things as maybe one of the answers. So again, I think I have never met somebody with diabetes who wants to feel like crap. Like, who genuinely is like, yeah, I want to feel like crap. I really don't want to try. I wrote a recent blog post for Center for Change where this whole calling people with diabetes compliant or not compliant, or using the words good control or bad control. I understand that is sort of old school language that I think a lot of people were taught and terminology that was used, but I think it can be really damning to somebody, right? Because there is a high burnout of diabetes. I've done presentations on diabetes burnout. It is very present, and I'll go to, again, my doctor's appointments. I go to a lot of them now that I'm pregnant. And they'll be like, well, you are doing so amazing, like just so incredible. Like, what are your secrets to tell my other patients with diabetes who are not compliant? And I just want to be like, oh, like it just stabs me because I'm like, this disease is so tough. It is so complicated. I think it can be so misunderstood. And again, this thought that people have given up, I don't think it's that anybody wants to give up. I think it's that they're exhausted. A lot of people don't have the resources. I'm doing good in my pregnancy because I have a husband who works for the federal government, has great insurance, has a great job. I have a job where I'm flexible enough where I can get off to go to medical appointments. We can, buy a variety of foods. I'm able to have a gym membership. Like, those are privileged things in America. And as Tamara said, and I've done full presentations on insulin affordability here in America, but for many Americans, almost 50% of those insulin dependent diabetics that I talked to you guys about, 7.5 million, have struggled to afford their insulin. You know, this is a hormone that every single one of us on this presentation, I can't see you, I wish I could all see your faces, all of our bodies make it. And if it doesn't make it, you have to buy it. And again, it was discovered over 100 years ago, and it costs pennies on the dollar to make. But here in America, a vial of insulin retails for about $350. I go through a vial every 2 weeks. Again, I'm in Minnesota. If I go 4 hours north to Canada, that same exact vial is $25, and I don't even need a prescription. And so again, we talk about what are these massive barriers for people with diabetes for access to healthcare and to medications. And we do have a big issue with that. So again, you know, are people's blood sugars more up and down? Are their A1Cs higher than people would like to see? When I say A1C, I mean hemoglobin A1C, which is kind of looking at the average of somebody with diabetes last 3 months of blood glucoses. So, you know, I think there's so many different things that play off each other, and we have to be really cognizant of that instead of just kind of looking at some numbers and making a judgment, or looking at somebody maybe who comes in whose eyesight is going, right? Maybe early stages of retinopathy, which is a complication of diabetes, or an amputation of a toe or a foot or a leg. You know, this is a very scary disease, and unfortunately, it is a disease where you don't get to take a day off. I don't get to take a day off. And it is every minute of every single day, right? I have this live webinar with all of you beautiful people today, and I have to, you know, in the first minute, give you guys the warning, oh, I may be, you know, my stuff may be beeping during the presentation. I'm sorry, right? Like, I have to be thinking about all that. How much insulin do I have left? What's my blood sugar? How could giving this presentation impact my blood sugar? So here's a picture of me at 13 years old when I was diagnosed with type 1 diabetes. You know, again, I was absolutely shocked. I was in denial that I got type 1 diabetes. And so, yes, there is a very strong medical component that I had to learn, my family had to learn about how to live with type 1 diabetes. And that learning is continuous, right? Type 1 diabetes, when I was diagnosed back in 1999, is a lot different than diabetes in 2023. It is a lot different. And pretty soon you'll hear kind of where I'm tying in about how complicated it is for somebody with diabetes, and kind of the demands that we have today. And then again, social media, and how that all kind of can get very convoluted. So again, so why is it so complicated, right? So we have the US Surgeon General saying we need to limit people's time on their phones, limit time on social media. And now, okay, you're somebody with type 1 diabetes like myself. I've had it for over 20 years, okay? So the diagnosis may be the same for people, but there are barriers to care, including financial, psychosocial, and health literacy, okay? So again, huge financial barrier in place. I actually married my husband early. We ran to a courthouse during the pandemic so that I could get on his insurance. I joke to people, but it's not a joke, you know, that the sexiest thing about my husband was that he had a good, reliable health insurance plan that covered people with diabetes. And I joke about it, but I'm also serious, and it's also kind of sad to me, right? And I know people who get married or don't get married, right, because they're having to make healthcare decisions, and that's really sad for me. So the majority of individuals with diabetes have not had any type of formal training or education. Again, a lot of times they're, you know, I grew up in a small town in Minnesota, so we didn't have an endocrinologist who is a diabetes specialist doctor on the disease of diabetes. So my parents, again, I was privileged to grow up in a middle-class family, drove my brother and I 2.5 hours away to the Twin Cities Metro to have care with a pediatric endocrinologist and a full comprehensive team. But we look at how now some parents have to work 2 to 3 jobs just to make ends meet. They don't have the gas money. They may not have the insurance coverage, right? If we have people in this country who can't even afford their life-saving medication, right? Additional diabetes education appointments with a nurse educator, a dietitian, a therapist who focuses on this area, that's out of the question, right? Those are kind of frivolous items. Less than 7% of those with private insurance and only 5% of Medicare beneficiaries use their DSME benefit within the first year after their diabetes diagnosis. So traditional education models often lack convenience, accessibility, and flexibility that many individuals with diabetes need, right? We have geographical barriers, we have cost barriers, we have insurance barriers. It's estimated that about 50% of those living with chronic illness do not take their medication as described. Again, contributing reasons, lack of adherence is complex and can be attributed to challenges related to the patient, healthcare providers, and healthcare systems. Research, I gotta move this thing again, sorry. Research demonstrates that individuals who receive diabetes education are more likely to use primary care and preventative services, take medications as prescribed, control their blood glucose, blood pressure, and cholesterol, and have lower healthcare costs. But again, there's a lot of reasons why somebody may not have that, right? And so, yes, best case scenario is giving them access to the experts in this field, right? Giving them the information that they so desperately need and deserve. But again, a lot of times the practicality of it is it does not work for people, or people just do not have access. There are major barriers in place. So social media and diabetes, patient engagement with diabetes self-care is critical to reducing the morbidity and the mortality. Again, people with diabetes are making 95 to 98% of their healthcare daily decisions. Again, their dosing of their insulin, what food they're going to have, checking their blood sugar. So social media has really come into this one form of digital health available for diabetes self-care, right? There's a whole diabetes online community trying to help people access information, to learn more about the disease, to learn kind of the tips or the tricks or recommendations. Where in the past, right, I would go to a diabetes nurse educator or my endocrinologist and get those recommendations. Those would be the people who would be kind of referring me or telling me kind of the pros and cons of different items. Now, oftentimes, right, like even with my pregnancy, I'm in a type 1 diabetes and pregnancy Facebook group that is phenomenal. I also understand, though, that a lot of times the people commenting and posting are other women just like me who have type 1 diabetes, who are pregnant, but we're not medical professionals, right? And so again, how do we educate people that yes, it can be a great free resource, but some information, right? What do they say? And I've done this in my pregnancy, but just like Google MD, right? Like we will Google things and then we'll just like cipher through all this information. And sometimes it's pretty morbid. And again, like even as developed adult brains, like how do we decipher what's good, what's bad, what may be true, what may not be true, things like that. So, we see the effectiveness of diabetes self-management education delivered through social media on glycemic control, so the hemoglobin A1C, knowledge, health-related quality of life, anxiety, depression, and self-efficacy in people with diabetes. So we know that if people have access to this information, right, they will do better, right? They will be able to better manage. And by the way, I prefer the word manage over control or compliance. I just think there's less blame and shame when we use that language. Social media, DSME can be effective in reducing those A1C levels, increasing the diabetes knowledge and self-efficacy. Again, self-efficacy, that confidence in oneself that they can master something, right? That they can execute something well. A lot of my graduate school research was specifically on that topic of self-efficacy and how communication messages from certain individuals can impact that positively or negatively. The present study investigated the role of social networks and showed that the influence of social networks is high among patients with diabetes. And these networks will improve diabetes and its complications by providing various self-care services. self-care education services provided through social networks can increase the in-depth knowledge for patients about self-care techniques and their effective role in controlling and managing diabetes and performing more self-care processes. So, and actually today, I think it was today or yesterday, I was emailed 2023 Google data reveals the state of diabetes in the United States. And it was really interesting. It was talking, there's an analysis done on Google searches in 2023 in regards to diabetes. And I'll just read a couple of the key takeaways, but it said Americans are actively seeking information about diabetes with over 261,000 monthly searches. This is more searches than healthy eating tips and fitness combined. But there's been a significant increase in searches about hormones and their role in diabetes, as well as inquiries about, gosh, I'm gonna botch this. My pharmacist father would be so embarrassed. Tirzepatide, a new medication. People researching about gestational diabetes. I thought this was very interesting. The states of Mississippi, West Virginia, Arkansas, Alabama, and Texas are most interested in diabetes searches. Their higher diabetes prevalence rate and limited healthcare access contributed to increased online searches, right? Which I think is really fascinating. What can we find on the web? Now, these are just my own screenshots, right? Oh, I could do a whole presentation on Halle Berry, but I will spare all of you my thoughts on Halle Berry and celebrities that have really hurt our cause. But Halle Berry says the keto diet has helped reverse her type 2 diabetes, right? And then because people see it online or social media and they see that Halle Berry said this, they must mean then Quinn Nystrom can reverse her type 2 diabetes, right? Or the amount of people who send me ideas about cinnamon or eating lemons like that will cure my diabetes is shocking. But there is no cure for type 1 or type 2 diabetes. So I'll just say that as a blanket statement. This was, I do a lot of work around insulin affordability, as I was saying. So I had done a video for Now This, which is a really popular social media site about insulin affordability. And I was like so thrilled. It went viral. There were hundreds of thousands of views. And I was like, oh, gosh, everybody's going to know about insulin affordability. And we're going to get passionate about it. And then I made the mistake of starting to read the comments, right? So somebody said, losing weight and eating better will help. Change your lifestyle and free from diabetes. Naturopathic and yoga, the only way, right? Or then, blaming it on sue the food suppliers contributing to this health problem, right? So, and then people, laughing and commenting, and there were thousands of these, right? These are just 3 that I put. Here, CNN posted a weekly dose of semaglutide, the key ingredient in blockbuster medications Ozempic and Wegovy, helped 7 out of 10 patients newly diagnosed with type 1 diabetes stop taking insulin after 3 to 6 months in a small study. Again, that is a news source tweeting that out. And again, I know people have the best intentions, so they're sending me this like, oh my gosh, Quinn, there's a cure for diabetes. Like, isn't this amazing? And like, I'm exhausted from having diabetes. And we've gotten a lot of false hope. When I was diagnosed with type 1, our pediatrician at the time said, if I could just hold on for 5 years, there'd be a cure for diabetes, right? That these top diabetes nonprofits had promised there'd be a cure in 5 years. How many times have I heard that? That is exhausting. It's giving false hope. People are burnt out with this disease. And so then you get false information and you get people sending it to you. You have people believing that maybe I'm not doing something to get rid of my diabetes, right? And so then there's no empathy that insulin's expensive because they believe it's my fault and I should just work out at the gym more or change my diet. I can't make this stuff up. Why sleeping naked could cut your risk of diabetes? Like, really? No, like, I wish, right? Okay, and there's so many more screenshots I could show all of you. My husband laughs because I just screenshot them all the time on my phone, and then I put new ones in for every presentation. So it's funny, but it's also scary, right? And so again, we know social media is an issue. You have diabetes, which there is a lot of misinformation, false information being pummeled out. People take it as truth, they send it to people with diabetes. We get false hopes. I think these narratives are created. There is shame that is being fueled by this. And then again, right? So I have type 1 diabetes. So, I'm blessed and lucky. I'm on a continuous glucose monitor. So I have an Apple Watch that has my blood sugar on it. So I have this screen. I have my iPhone, which has my blood sugar on it as well, right? That will alarm. And then I have this that looks very closely like a cell phone, but it's not. This is my insulin pump. This is my PDM, my personal diabetes, what is it? PDM manager, I think it is. I personally wear an Omnipod insulin pump. So it's a tubeless pump. This is how I give myself insulin. So again, right, I'm connected to all these screens. That is the best available care for somebody with type 1 diabetes, but it puts me even more time on my phone, even more on my screens, even more connected on my watch, dinging me if my blood sugar is going up or down. Or again, when I was diagnosed in the 90s, I tested my blood sugar about 4 times a day. And those were the only blood sugars I knew. Maybe on a sick day, I would test a little bit more than that. But again, insurances usually only would cover 4 strips a day. And so that's what you did, right? So again, just all this like information just funneling to you, which again, there is a positive, but there is a negative. So, here are some used strategies, right? What can we do to protect ourselves as savvy social media users? Reach out for help, create boundaries to help balance online, offline activities. Be cautious about what you are sharing. Oh, I'm sorry, I switched that too soon. Develop protective strategies and healthy practices. Protect yourself and others. Again, really having open conversations at home, as well as healthcare providers, having those conversations with younger people. What are action items for guardians, right? Creating a family media plan, creating tech-free zones, and encouraging children to foster in-person friendships. Model responsible social media behavior, right? If we're a parent, and again, I'm guilty, I'm on my phone all the time, what are my kids gonna think, right? So teach kids about technology, empower them to be responsible online participants, report cyberbullying, online abuse, and exploitation, work with other guardians, schools, and local organizations to help establish those practices. For people with diabetes, again, we know it's so much more complicated. So be proactive in educating patients about the harms and the benefits of social media. Because if I'm seeing these harmful things about diabetes online, so are they. Create a positive influence list to recommend. I have a list, I'm happy to give that out to anybody who wants to email me. Recognize why patients go on the web to seek medical advice and understanding. They're not trying to negate the medical experts. A lot of times, right, there's a cost barrier, there's a time barrier. Dispel the myths to patients and support people, be an advocate for them, and again, be viewed as the expert, but also the confidant where they can come to, where they can feel safe to talk about how they may not have been able to pick up their insulin because they couldn't afford it, or they're trying to work 3 jobs and they can't fit in their annual appointment. There's a lot of different things around. Real quick, so a couple of positive pages that I follow. Body Positivities. I just love this page. It's just honest, it's truthful, it's relatable. She just has a lot of great stuff. We didn't talk a lot about body image, but I think it's a very pertinent thing for people with diabetes. And so I have a full list. If you want the list, please message me. I'm happy to do it. And now I know I brought us to almost the very end of the hour, but here's my information if you want to connect, or email me questions if your question is not asked and answered today. And again, thank you so much for joining, and I will give it back to Tamara.
Thank you, Quinn. Excuse me, thank you. We have a ton of questions and we won't be able to get to all of them. So make a note of Quinn's contact information that she has there on the screen. If you have a burning question that we can't get to and you really need to know, feel free to reach out. You can also reach out to me at cfcwebinar@gmail.com. It's the email address that you see on all of the information that comes from GoToWebinar. So you can reach out to me and I'd be happy to pass along the information. I know it's the top of the hour. Most of you or some of you have to hop off. Before you do that, I want to just give you 2 quick reminders and then we'll get to questions. The first reminder is that when the webinar ends, or if you end it first, you leave to go to a session or whatever, you'll see a pop-up on your screen. That's the evaluation for the webinar. if you would take just a minute, please, to fill that out, that would be really helpful for us. That's a continuing education requirement for us. It's completely anonymous, so please feel free to be candid in your feedback. Once we have all of that information, we tabulate those results, send those to the continuing education providers. That's part of the requirement for us. And then what you all want to know is, how do I get credit? How do I take the test? Just a reminder that you'll get an email about an hour after the webinar ends. You'll get a separate email. It will look similar to the email you got from GoToWebinar when you first registered. You'll see a new email about an hour after the webinar ends with the link to take the test. Once you take the test and you pass it, then you'll see a little button on your screen that allows you to print or download your certificate. So look for that there. All right, Quinn. Here we go. There were, these first several questions were about the diatribe chart of 42 factors that affect blood sugar. So there, let me find, let's see. One of the things that you had on the list is celiacs. And so Natalie's asking, what is the connection between celiacs and diabetes? Are they commonly diagnosed together? And maybe you can speak to that real quick.
Yeah, so again, I'm not a medical expert at all. I just know that especially over the last couple years, what we have seen, especially with the rise in a lot of different kind of food allergies, things like that, people with an autoimmune disease like type 1 diabetes are at a higher risk for celiacs. We know that now. There's more research that is being done, which I think is really important. There's also more knowledge in the medical community to, again, every couple years to test somebody with type 1 diabetes for celiacs, because again, I think we just didn't have a ton of knowledge about celiacs, 25 years ago. And now there is more information, more conversation. So we do see a high correlation. My brother and I don't have celiacs, but I will tell you our endocrinologist does that quick test for us every couple of years just to make sure that that is not something else that is a struggle for us.
Got it. On that same chart, there are some that are listed on the chart that have an up arrow and a down arrow. So Kathy just wanted some clarification. What does that mean? Does that mean it could go either way, correct?
Yes, Kathy, that is why diabetes can be so complicated, so confusing, and so exhausting. Because for instance, all right, for me, I like to go to Orange Theory, which is like a high intensity, HIIT workout class. Some days I go into that class, my blood sugar is like at 140 going in. And for some reason during that class, which is the same 60-minute class for the most part, it will go up, right? I have no idea. Other days, the last couple of times I've taken it, it has dropped down. And like, again, I work with my diabetes team to try to figure out, like, I don't want to drop low. I don't want to go up during a workout class, right? I have to leave, I have to have sugar, but sometimes it happens. So every person with type 1 diabetes and type 2 diabetes, like our blood sugars are impacted differently. And sometimes the same exact activity, or sometimes even the same food, can have a different impact. And that can make it even more frustrating, more complicated, and more difficult, and why a lot of us are really tired.
Thank you. All right, Margaret asked, what wording would you use instead of compliant/non-compliant? And what folks don't know is that Quinn does a full presentation just on that. It's about language to use as a professional, etc. So we'll save that big long one for another day, but maybe you can give a quick answer to wording that would be helpful rather than compliant, non-compliant.
Yeah, and again, I recognize that, again, that was the language that was always used. Starting out when I was diagnosed in the 90s, that is what was used, right? It was sort of good, bad, compliant, not compliant, control, uncontrolled. The word that I prefer is the word managed, because I think when you talk about compliant or uncompliant, or you talk about controlled or uncontrolled, there's a big onus going on to that individual. And because I live with diabetes 24/7, if somebody is using things like you're not compliant, what I'm interpreting, no matter what your best meaning is you're saying, I'm not doing a good job. I'm not working hard enough. I'm not smart enough. I'm not on top of it enough. And for most people, right, that is demoralizing. It puts you down. Again, sometimes there's just a lot of different barriers that you may not even know about, right? They may be going through family struggles, that stress is just causing up the roof, right, with blood sugar issues, and they don't know how to manage it, right? They can't get out of their family. And so I think using the word manage is, okay, what tools are we giving people? What barriers are we working together to overcome, right? Manage is more, I just think puts less shame. You know, is it the perfect word? Probably not. It's like, you know, they used to say a blood sugar test, right? They'd say, test your blood sugar, okay? Well, if you think about a test, there's usually a pass or fail to that. There's a grade put on that. There's a worth put on that. I loved Ann Goebel-Fabry, who's just phenomenal in the world of diabetes and eating disorders. She's a psychologist out of the East Coast, but she talks about your blood sugar should be a check, just simply a check, right? And it's a compass. It is not a test of a pass fail. It's to help us decide what's the next best thing to do. What's the next best decision to do? It's not about like trying to take somebody down because they had a bad blood sugar, right? It's good because you know what the blood sugar is. Now you have more information than before and you can make better decisions moving forward.
Thank you, Quinn. We have both Elizabeth and Aliona, I hope I'm saying that right. Both asked about the DSME benefit. What does DSME mean and what is that?
So a lot of insurances, and again, things have gotten better with the Affordable Care Act, but again, we still have a long way to go in good, affordable access for all Americans for health insurance. But that is talking about, do we have, I'm just boiling it down in a very simple term, but does your health insurance cover diabetes education? So again, if I'm diagnosed with diabetes, there is a massive learning curve, right? Because now I'm having to play pancreas every minute of every day. I don't have that knowledge as a 13-year-old girl, nor does my family have that knowledge. So does my insurance cover for me to be able to go into a diabetes nurse educator? We have a lot of certified diabetes educators who are dietitians who can teach us how to carb count. Because again, anything that I put in my body, I have to know the carb count, because I have to then, I have this equation that my endocrinologist gave me of how many insulin units per gram of carbohydrate, right, that I'm calculating how much I'm putting in. Now, most of us probably are not professional carb counters unless we're a devotee of the keto diet, right, or the Atkins diet, which I have other presentations, as Tamara knows, about the dangers of all of that. But the point is a lot of our health insurances do not cover that, or maybe they cover it and patients don't know about it. So again, where are they going? They're going to social media and the internet to try to get their information and their education, which again, sometimes can be helpful, and sometimes they can be getting misinformation. And that's where I think it becomes very complicated for people with diabetes, because they're really trying to decipher, again, a very complicated disease to manage, and there's misinformation out there, right? Like the keto diet, I'm sorry, if I could do the keto diet and cure diabetes, like sign me up. But unfortunately, that's not the case.
Speaking of misinformation, we'll do this last question and then we got to let folks go because we're way over. Courtney asked, have you seen misinformation about diabetes that have an impact on those with an eating disorder?
Yes.
Totally,
yeah.
Right?
And as Tamara knows, I mean, that's why I teamed up with Center for Change, because again, myself, long struggled with an eating disorder and type 1 diabetes. Again, you think about all this information that we have to be taught to simply stay alive with type 1 diabetes, right? I have to be taught, you know, I need to be checking my blood sugar. I need to be carb counting everything. I have to be looking at nutritional labels. There's a hyper focus on my body. Then there's an outside influence, not just from the medical community, but people in general who have very strong opinions sometimes about diabetes. Tamara and I'll tell her horror stories of like the diabetic food police, like, you know, being at events with Tamara where people are like, are you sure you should be eating that, Quinn? And it's like, why, is it yours? Like, I don't understand why, like, I can't have this.
Right,
and so,
right.
Again, misinformation fueling that. And then again, me not seeing it for what it is, and then thinking people are thinking that I've caused this disease, that I've caused this epidemic, that I've caused the financial burden of living with diabetes, and this heavy emphasis on our body and giving ourselves injections, right? So we're very aware of our body, of the fat that we have, right? We have to squeeze parts of fat of our body to give ourselves insulin injections. And so all of that unfortunately fuels, I think, a decrease in body image, satisfaction overall, and then really, again, eating disorders. We see a much higher prevalence with people with diabetes. That's why Center for Change is amazing, because they're experts in it. But we also see people even with disordered eating, right? And so it's very complicated. And again, it's just putting another barrier in place. Great question.
Thank you, Quinn. We're so happy you all could join us today. Thank you again so much. It's been our pleasure to be able to provide webinars for you all this year, and we're doing more in 2024. I'm excited to tell you that those of you who know Dr. Heather Finley, who's a dietitian who does gut brain and is a phenomenal presenter, is doing our first 2 webinars in January and February in the new year. So keep an eye on our website for more information about those webinars upcoming. My thanks to Quinn today for a great presentation, and my thanks to all of you for being with us. And with that, we'll let you go. Please take good care, and we'll see you hopefully again soon. Bye-bye.
Thanks, everybody.